Hello, and welcome to our live webcast, Cartilage Injuries of the Knee. Know when to scope them, know when to grow them, know when to inject, know when to replace. Thank you for joining us. My name is Megan, and I will be the operator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. On the right-hand side of your screen, you will see the text chat window. There is a large window which holds all your sent messages and a smaller text box at the bottom where you will type in your questions. To send a question, click in the text box and type your text. When finished, click the send button. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order in which they were received and will be addressed at the end of the presentation. At the conclusion of today's program, we ask that you complete a brief post-event evaluation. Please take a moment to complete this survey in order to receive credit for providing feedback and attending today's webinar. We are joined today by our speaker, Dr. Jonathan Roth, board-certified, fellowship-trained orthopedic surgeon who is part of Atlantic Medical Group's Ortho-Care Wayne practice. Dr. Roth provides both operative and non-operative therapies. And at this time, I'd like to turn the microphone over to our speaker, Dr. Roth, for opening remarks.
All right. Hi. Good evening, everyone. Thanks for joining us for this webinar. Tonight, I'm going to talk about cartilage injuries of the knee, and we're going to go over various types of treatment options, first how to evaluate them, and then go into what can be done about them, anywhere from fixing cartilage all the way up to replacing it. I am a board-certified, fellowship-trained sports medicine surgeon, so my goal with most of my patients is to save the cartilage or regrow it. But when it becomes too much, then I tend to get them over to my colleagues who can do a replacement. And so we'll talk about all different types of cartilage injuries of the knee, all different types of treatment for these cartilage injuries. But my presentation and most of my details will be regarding how to save the cartilage, and that's kind of my specialty. So without further ado, let's get started. As a disclosure, I have no conflicts of interest. I have no relationship to any company or product. And I'd like to thank one of my fellowship mentors, Dr. Allison Toth. She is still at Duke University Sports Science Institute, and she not only helped a little bit with this presentation in the past, but taught me a lot about all these techniques. So as I said tonight, we're going to go over some anatomy and pathology regarding cartilage and cartilage injuries. We're going to go over history and physical exam findings. We're going to look at some imaging, which imaging to get and why. And then we'll go over the treatment options, both non-operative and operative. And finally, at the end of the talk, we'll go over my algorithm with how to evaluate and how to decide on which treatment is going to be best. So the background, these are pictures of cartilage. And cartilage, as you can see in these images, is a highly organized, it's viscoelastic, and it is relatively acellular, connective tissue, and it reduces friction and helps share load at every articulating joint in our body. And it's primarily composed of hydrated gel matrix, and within it there's collagen, hyaluronic acid, aggregans, proteoglycans, and they're all synthesized by the cells called chondrocytes. This collagen network that it's in is primarily of type 2 collagen, which gives it its strength and integrity. This is very important because the tissue generated, as we'll talk about later in a lot of our repair techniques, ends up being type 1 collagen, which is not as strong, and it's more of an indication of an ossification instead of a cartilaginous repair. When the cartilage gets injured, it can injure superficially towards the top layers or all the way down to what we call the tide mark, which is the area of junction between the cartilage and the bone underneath. The cartilage itself lacks any vascularity, so it can't necessarily heal on its own because it doesn't get a blood supply. It also doesn't have any neural elements, so you can't feel necessarily an injury to the cartilage itself, but the bone underneath has a lot of neural elements, and what patients tend to feel is the increased stress in the bone underneath as the cartilage either wears out or sloughs off or gets a fissure in it. As I said, if it gets below the tide mark, it gets into bone, and that bone can then produce type 1 collagen as a scar, which is not as strong as its native type 2 collagen in the cartilage. Injuries can be anywhere from trauma, chondrolysis from a medication, increased stress from malalignment, genetics play a big role, as well as some idiopathic injuries such as osteochondritis dissecans. In a study all the way back in 2004 out of a large center out of Oslo, one of the foremost centers in cartilage research, they looked at 933 knees in just regular knee arthroscopies, oftentimes done for meniscal injuries, patellar alignment, ligamentous injuries, or just diagnostic knee arthroscopy. And even in those patients that they didn't expect to see any cartilage injuries, they found 20% of patients had some kind of cartilage lesion. Out of those 20%, almost half were full thickness. So how can we identify patients with cartilage injuries? First, with a history. Oftentimes they come in and patients can have a swollen knee. They may have a mechanism of injury, such as a twisting, injury, a fall, a deep squat, a hyperextension. Sometimes they're atraumatic. They just wake up and they have pain and they can't remember how it happened. With the onset and pattern, we can tell whether this is going to be maybe a focal injury or more of a degenerative process. If there was an acute event that led to swelling and pain, that may be this focal chondral or osteochondral injury. If it's repetitive injury, gradual over time, that's more indicative of a degenerative injury. In the history, patients will often also report persistent pain with weight-bearing activities that load the chondral defect. So it depends on where the injury is. It would lead to pain at certain motions of the knee. If it is where they make contact when the knee is fully extended, then just straight weight-bearing standing up may cause pain. However, if it's in either the flexion weight-bearing surface or underneath the kneecap, it may be more in a flexed position, such as sitting to standing, going upstairs. So those are ways to help think about where the injury may be happening prior to getting any kind of actual radiographic imaging. Some patients may have mechanical symptoms. This is a big red flag when patients come in and have either catching or locking episodes of their knee. And this may tell us that there's a loose body or there's an unstable cartilage flap as seen in this picture. And this can also help us determine whether there could be a response to certain types of treatment, whether non-operative or operative. So after a thorough history, we get a thorough physical exam, and these should always include evaluations of effusions and ask the patient whether they're acute or whether this is persistent on and off. We should look at their range of motion and see whether they have a loss of active extension or flexion, whether there's a feeling of a loose body, such as a locking of the knee, unable to reach the same range of motion as the opposite side, feeling like something gets stuck within the knee. Also, limb alignment. We should have them stand up and look at how their knees are aligned, whether they're bowed in, bowed out, or straight, and compare it to the opposite side as well. We should always look at ligamentous stability, because that could play a role in further treatment or cause of injury. Along with that, we should also look for other than limb alignment, look for patellar alignment, look for limb length discrepancy, as well as neurovascular status, obviously. So for radiographs, we always, in our orthopedic office, get standing weight-bearing films if possible. And this is a big star and something to remember from this talk. If you're evaluating a knee, if the patient can stand up for an x-ray, they should be standing for the x-ray. And we try to get, if possible, 4 views: an AP, a lateral, a sunrise view or a merchant view that looks at the patellofemoral joint, and as well as this Rosenberg view, which is a 45-degree flexion PA weight-bearing view. And you can see the picture here about how it's done. This looks at the more flexion weight-bearing surface of the femur instead of the true AP, which looks at the extension weight-bearing alignment of the femur. And oftentimes, these two can be different. In a true AP, they may not be any joint space narrowing, but once they start bending their knee, there can be significant joint space narrowing, indicative of significant knee arthritis, which may tell us that our future treatments may not be successful. If you have any concern for malalignment of the knee, you should also get long leg alignment views that goes from the hip all the way down to the ankle, weight bearing, and we can see where the weight bearing axis goes through the knee. It should be going nearly right through the middle of the knee. Oftentimes in patients with arthritis or malalignment, it is far over to one side or the other. Overloading that area of the knee can cause pain, and this may also guide us in further treatment to realign the knee and move weight off of an injured area. This is a view of the difference between a non-weight-bearing knee and a weight-bearing knee in the same patient. And as you can see on the left, non-weight-bearing view, the knee looks awfully good with good joint space both medially and laterally. However, let me see if I can bring this up. On the medial side, non-weight-bearing, there's still space. However, once they put weight on the knee, you can see the joint space is gone. And that is a sign of full thickness cartilage loss, and that is pretty significant arthritis right there. This can really help us determine treatment options and whether restorative procedures will be successful or whether we'd have to consider replacing the knee. MRIs are good at looking at ligament and meniscal integrity. It can also look at subchondral edema, which is a sign of increased stress within the bone since the cartilage may be lost. We look at the fat suppressed as well as special studies like fat spin echo sequences, which increased magnet strength allow for a more accurate assessment of the articular cartilage. When getting an MRI, I oftentimes tell patients, if they're not going to a recommended place that we know, to make sure that the magnet they get the MRI done in is at least 1 Tesla, if not larger. 1.5 is pretty standard for a closed MRI, but they even go up to 3 Teslas, and that's the strength of the magnet. Usually the open MRIs these days can only be 0.3 Teslas, which is 1/5 to 1/10 the strength, and therefore much less quality imaging with a lot more static inability to really visualize the small injuries. In academic centers, they have these advanced MRI techniques to really look at cartilage. This is more for research, and it's not really done in community centers or private MRI groups or imaging centers. But you may hear about these. T2 mapping can look at collagen with a heat map, and you can see where cartilage is thick or thin. Then there's others called T1 row and degemeric. Looking at degemeric, it can really assess quality of repair tissue. Again, this is more for for research and not very worthwhile for an everyday practitioner. Finally, for assessment, if all else fails, a diagnostic arthroscopy can be performed. If the MRI is inconclusive, if the patient continues to have symptoms despite non-operative treatment, if there's catching but it can't be found with all of our prior testing, we can offer a knee arthroscopy for diagnostic evaluation, as we're now visualizing the cartilage with our eyes. And we can see if there's a flap like you can see in the picture before, and we can remove the flap and clean it up, and you can see what it would look like after. So how do we grade our arthritis or cartilage injury? Outerbridge described this all the way back in 1961, and we still use this today. Grade 1 would be softening of the cartilage. We can put our probe on it and it kind of dimples in, but it's otherwise intact. Grade 2 is some light fraying up on the surface. Grade 3 is a fissure all the way down to bone with potentially some loose flaps, and then grade 4 would be some exposed subchondral bone. And this is grade 4 along with what looks like a bony defect in the bed as well. I like to look at these like a road, and this is how I talk to patients. I say, you know, no arthritis is like a freshly paved road. It's very smooth on your tires. You can barely feel it. With age and wear and tear, you can start to get some cracks in the road, but the pieces are still intact. You can't see the dirt underneath. Grade 3 would be starting to see the dirt underneath, and grade 4 would be a big pothole. Now, grade 4 with bone loss underneath would be a large pothole with loss of dirt underneath, such as this picture in the bottom. So remember these pictures, and we'll keep going over them as we talk about treatment options. Now, in literature, as well as in our minds when we think about chondral lesions, there's many variables that go into how to describe them and then how to treat them. So they can be both lesion-specific or patient-specific. Lesion-specific, we look at location, where on the condyle or where in the knee, the depth, the geometry, whether it's contained, and containment means whether it's on the edge of the bone and there's kind of a loose edge going off, or whether there may be a real rim of good cartilage around the lesion, as well as the cause. Is it an osteochondritis dissecans? Is it trauma? Is it from chondrolysis? Is there another reason? And then patient-specific, we definitely want to look at age. We want to look at how long the symptoms have been going on for, what types of symptoms they have, any medical comorbidities, their activity level and demand, and what their expectations are for afterwards, as well as alignment, stability, any prior treatments, the status of the meniscus. These all play a role in what future treatments we can offer them. So going back to the road analogy, depth and location, sometimes it goes all the way down into bone and sometimes it's pretty shallow. Size and containment, something like this may not be contained because it's going off the road, but while something like this is still within the road, as there's still good road on this side as well as on this side. And how long is it? Is it going all the way up and down the condyle? Is it very large, or are these focal potholes along the road? So taking all that in, we have various options to treat this. Some are palliative, and those include just injections, bracing, debridement lavage, as well as an osteotomy, which is a large surgery, but it doesn't address the cartilage specifically. It addresses the alignment and reducing pressure on the cartilage, so it is still considered a palliative option. Reparative would be considered what we call a microfracture, which we'll go into. And then there's restorative, which we can try to grow cartilage back, real cartilage with type 2 collagen instead of microfracture, which would be a type 1 collagen. And then finally, when all else fails, there's arthroplasty, where we replace the cartilage with metal and plastic, and that's always our last option. That can be considered kind of the last option if all else fails. And you can see we're going to go over these, but they go from cheap to very expensive, easy to challenging, and then as it gets more expensive and more challenging, it turns into more real cartilage replacement or restoration instead of fibrocartilage type 1 like we had mentioned before. So oftentimes our initial management with any cartilage injury is non-operative. If a patient's diagnosed, if there's degenerative cartilage wear, if it's a partial thickness injury, we typically start with initial conservative management. If they're overweight, we definitely discuss weight loss, as increased weight above the knee can put a lot of extra stress across the knee. So that's something always to discuss with any overweight patient. We can start with anti-inflammatories, acetaminophen, glucosamine chondroitin supplementation. There's even studies that say turmeric, ginger extract, and vitamin D can all help with improving pain and function. We then start considering injections, both steroid injections and hyaluronic acid injections. Physical therapy can help improve strength and flexibility around the knee, as well as stabilization of the knee. And if there's malalignment of the knee, as well as unicompartmental cartilage loss on the side with increased stress, then we can use an unloader brace, which helps push the knee in one direction to kind of shift the forces away from the high force area. So in this knee here, the alignment, this is a long leg alignment film like we talked about before. The weight-bearing axis is going through the lateral side of the knee. It should be going right through the middle right there. So an unloader brace, this will be called a lateral unloader, will push the knee this way and get the weight-bearing axis to start going more towards the medial side of the knee, reducing stress across the lateral side. So as I said, injections. First injection that we can consider is a steroid injection. This is a strong anti-inflammatory going right into the knee to reduce inflammation. Typical steroids we use in the knee are depomedrol or triamcinolone. There's some research out there that shows that triamcinolone may be more helpful with inflammation in the knee. And there's a new one on the market called Zilretta. It's triamcinolone trapped in these microspheres. As it's injected, it slowly releases over time, which may, one, prolong the effects of the triamcinolone in the knee, giving more lasting relief, as well as may not affect, say, blood sugar in diabetics as much. So it's something to consider. One problem with Zilretta is while it is covered by insurance, it needs authorization. So oftentimes it can't be done on the same day as a visit. It may be tough to get authorization from an insurance company, and then the preparation is a little different in the preparation room than, say, a regular steroid injection, and so it has to be taught to whoever is preparing it and then delivering it. So the pros, let's remove that. The pros of a steroid injection, it is anti-inflammatory. It can give pain relief. It can give short-term pain relief even up to 3 months. And these extended release steroids, such as Zilretta, may give better outcomes long-term. The cons, though, it may accelerate osteoarthritis as it can lead to some chondrolysis. It can increase fasting blood sugars, especially in patients with diabetes, and so it should be used with caution in patients with diabetes, especially not very well-controlled diabetes. There's a chance it may lower someone's immune response, and so especially around now as people are getting vaccines, it is recommended not to give a steroid injection in a joint 2 weeks prior to receiving a vaccine or even 1 week after receiving a vaccine. And as I said, the extended release steroids, while maybe giving better outcomes, needs authorization with an insurance company and can be a little bit of a problem to get. Some of these statements, these are all out of this, the American Academy of Orthopedic Surgeons puts out evidence-based clinical practice guidelines often for various topics. And very recently, in August of this past year, they just released the 3rd edition discussing management of osteoarthritis of the knee, non-arthroplasty. So all treatments prior to replacing a joint. And so a lot of what we're talking about today are in these clinical practice guidelines set forth by our National Academy. And so this is a collection of data with some top-level experts in the field deciding what is good data, what is bad data, and what's recommended and not. Another type of injection is hyaluronic acid. Hyaluronic acid is a part of our natural joint fluid, and as we have worsening arthritis or cartilage loss, the joint fluid loses hyaluronic acid and becomes less viscous. It gets pretty thin. So hyaluronic acid injections can improve the viscosity as well as elasticity of the joint fluid, maybe giving a quote-unquote cushion to the knee. I like to relate it to patients as new oil for your car engine to give it better lubrication, reduce friction, and therefore hopefully reduce pain. As you can see at the top, there are various products on the market. There's probably about a dozen. These are just a handful of them. They come in 1-shot series, 2-shot series, 3 or even 5-shot series. When it's multiple shots, they're given once a week for those amount of weeks. And they're proprietary per company with various molecular weights, whether they're cross-linked or not, and then whether they're synthetic made or derived from chicken comb, and chicken comb has hyaluronic acid in it. So a lot of patients come in saying, I'm interested in the chicken comb, can you tell me more about it? And that's oftentimes what they're talking about. So the pros of hyaluronic acid, it has very minimal potential side effects. Patients with poultry allergies, you don't want to give the ones that have that are made with chicken comb, but can be given the synthetic versions. Some people have a reaction to them and can have a sterile effusion. There was one way back many years ago that was more prevalent at causing sterile effusions, but I haven't seen that probably in 5 or 10 years at this point. And then the infection risk of any time of giving an injection into the body. Other than that, there's no effects on blood sugars like steroids or any other medical condition. It can be helpful for up to 6+ months, and it is covered by insurance with authorization. The downsides is it gives variable results. Some companies have said that it works 80% of the time. Others, studies not related to industry, give it about a 50-50. And so our clinical practice guidelines say it's not recommended for routine use in treatment of symptomatic knee OA. I tend to use it as a 2nd or 3rd line treatment if all else is failing, or in patients who have diabetes and can't get steroid injections, want to avoid surgery, we want to try other things. Other types of injections out there for arthritis include PRP, which is platelet-rich plasma, stem cell injections, whether they come from fat or bone marrow, prolotherapy, which is a sugar solution injected. I'm going to only talk about PRP here, as the others are even more experimental. PRP injections, platelet-rich plasma, there's various preparations. We take blood out of the arm usually in the office, spin it down in a centrifuge, and can take off the buffy coat layer, which is a platelet-rich plasma layer. And depending on how you prepare it and spin it, you can either have leukocytes in it or not in it. And we call those either leukocyte-rich or poor. And depending on the type of preparation, they may be better for joint use versus tendon use versus other use. And this may reduce pain and improve function as talked about in our clinical practice guidelines. So it is an option, a recommended option that, again, may help. The downside to PRP is it is not covered by any insurance and can get expensive, typically about $1,000 a shot, plus or minus, and patients may need up to 3 shots at a time. And really, right now, we don't quite know long-term benefit. There are limited or mixed results out there. Some side effects that have been noted have been hypertension as well as proteinuria. Some studies, though, do show that it is better than hyaluronic acid, up to 12 months of improvement in pain, and it's possibly better than a steroid. However, more research is needed to evaluate whether this can cause cartilage injury over time with the chemicals, the natural chemicals in our platelets that are released, whether they can cause cartilage injury. Other non-operative treatments that have been shown to give benefit, again related back to our CPGs, is massage, acupuncture, laser treatments, transcutaneous or percutaneous nerve stimulation, pulsed electromagnetic field therapy, shockwave therapy, or denervation therapy. These are oftentimes done by either therapists, primary care sports medicine doctors, physiatrists, or pain management in order to offer other treatments outside of surgery. And this is more for arthritis when the knee has full thickness cartilage loss or gross cartilage loss and not a focal cartilage lesion. Now we get into surgical treatments. As you can see, just like non-operative treatments, there are a variety of surgical treatments depending on the type of lesion and all those variables we mentioned before. Lavage and debridement is an arthroscopic look inside the knee, and it tends to wash out any joint fluid or any chemicals within the joint fluid that may be pro-inflammatory. And debridement oftentimes is related to removing loose bodies or loose flaps of cartilage, and this can provide some temporary relief of symptoms. Again, looking at our practice guidelines, it is not recommended in most cases. However, it may be indicated in patients who have a mechanical symptom related to these loose bodies, such as catching, locking, or very painful clicking in the knee. We tend to reserve these for older or lower demand patients with degenerative injuries, people who may not want to proceed with a knee replacement, may not be able to due to medical conditions. It can give relief from these removal of the cartilage fragments or dilute some inflammatory mediators. However, these benefits deteriorate pretty quickly over time and may only last several months after a surgery. So it would be a long discussion with the patient as to whether that is something that's worth it to them to only gain several months of relief for undergoing a surgery. Now, if there is a focal area of cartilage loss, we can do something called microfracture. And this is where if there's exposed bone, we can use awls or drills to drill into the marrow of the bone and have marrow elements come out of those holes and basically cause a scab. This is ideal for young patients with no bony loss underneath, with these very focal, small, grade 3 or 4 lesions, usually less than 2 centimeters squared, with well-defined borders. We do not want to do this in anyone who has significant subchondral bone loss or malalignment or lesions on both sides of a joint, such as on the femur and the tibia, or in the trochlea and the patella. And as I said before, this will cause fibrocartilage formation, so type 1 collagen, which is not as strong or as elastic as the native type 2 collagen, so it doesn't last quite as long. And it disrupts the subchondral bone, which may cause problems for the future. As I said, there's 2 different techniques, drilling or picking. Picking uses this sharp awl that you can see in the picture, and it pokes a hole. It compresses the bone to the edges and may actually block marrow from coming out, while a drill will kind of remove a hole all the way into the marrow cavity and allow the good marrow elements to come out of the canal. As I said, fibrocartilage that is formed is mostly of type 1, so it's softer and less durable. The mesenchymal stem cells that's within the bone marrow that we want to come out are typically expressed to differentiate into this fibrocartilage and not actually hyaline cartilage. These same cell progenitors are based in the biology of connective tissue that forms scar, like I said. And while the concentration sounds like it's a lot, a typical concentration of what comes out of these microfracture holes is only about 0.2 milliliters, so it's only as low as 20 to 30 total stem cells per chondral lesion, which is not very much. So who do we select this for? Again, most common are medial-sided knee injuries and more femur than tibia, tend to be small, less than 2 to 4 centimeters squared. Younger defects, so more recent injuries. And the age of the patient, we want to see patients usually less than 30 to 40 years old get this, because after 40 years old, it's been shown that there may be some cell senescence of the stem cells, and they may actually not grow into what we want them to grow into and help. And so this may not be helpful. So again, we try to reserve this for under 40 years old. Looking at microfracture versus some more advanced procedures, they were pretty equal at 2 years, but then it dropped off, and these advanced procedures had better results looking more midterm to long-term at 5 and 10 years. And there was more real articular hyaline cartilage produced with these advanced techniques than with microfracture, and better outcomes with the advanced procedures. So again, microfracture typically reserved for smaller lesions where it may be easier to get done than do these large, more advanced procedures. Seeing that the results of microfracture haven't been excellent, we've tried to figure out ways to augment it. And so one option is this product called Biocartilage, which is a minced cartilage allograft that's mixed with PRP, and it's implanted into a microfracture site and then held in place with a fibrin glue to hopefully trigger that area to grow articular cartilage, hyaline cartilage, than that fiber cartilage. Another option would be Cartiform, which is actually an allograft cartilage disc, so a donor cartilage disc with a very thin area of bone on the undersurface, and it's implanted over a microfracture site and held in place with sutures or anchors. And the goal is for the bony bed to then bond to that thin bone of the undersurface of this graft and then fill in with cartilage. And we already know that that surface of that graft is already type 2 hyaline cartilage. And you can see this study showed that the center area is the disc, and the outside is the host tissue. And when they stained it, it stained for real hyaline cartilage, still healthy and still bonded now to the bone underneath. So this is another option. The downside of this is it would have to be a big open incision. It's very hard to do this arthroscopically. And you have to be prepared to have this on hand in order to put it in. So what happens when you have a bone lesion underneath the cartilage loss? And so this is something where we try to plug the defect, where we want something with bone and cartilage. And so the first option is an autograft taken from the patient's own knee. We can take a piece of cartilage and bone from another part of the same knee and transfer it into the defect that bears weight. This has a live, healthy cartilage on it. It has a live, healthy bone. It's not donor tissue. And this is ideal for a smaller lesion, 1 to 2 centimeters in diameter, typically of the femur, with bone loss up to about 8 millimeters or more. Though this can be done to the patella, the trochlea, very difficult to be done to the tibia. Contraindications, again, will be limb malalignment or maintained limb malalignment, loss of meniscus, bipolar lesions, like we said. And again, patella, possible contraindication, though it can be done. And this is how it is done. We typically harvest from an area that doesn't see a lot of weight bearing, such as the far lateral femur or around the intercondylar notch, and we put it into where the lesion is, where there's more weight bearing. You can see kind of a donor site here with the recipient site here, donor sites here to here, or there to there. Disadvantages are they're left with a hole in a different area, so it's stealing from Peter to pay Paul. And then there's still limited donor tissue available because we can only take so much from a certain area before it causes problems. But the technique is relatively simple. We measure the lesion, we get a harvester, and we core out the area of the lesion. The donor plug is created in a similar fashion, and just like whoever plays golf has seen them replace the golf hole and move it around the green, you can take a patch of grass and dirt from one side, put it in the hole, and put the golf hole in a different location. And it's critical that we make the final plug be flush with the articular surface. Otherwise, there's going to be a step off and rubbing. But you can see the cartilage lesion. This is an actual patella where cartilage lesion here on the patella, and it's filled with 3 small plugs. And then a repeat MRI shows that the plug is bonded in the bone with a flush cartilage edge here with good still cartilage on top of the plug there. And the oats have been shown to be better than microfracture even at 10 years. This one study, prospective randomized, showed 15 total failures. 4 of them were in the oats and 11 were in the microfracture. So, and you can see that the failures kind of stopped at around 3 to 4 years, and anyone who survived that long with good results tend to keep having good results even up to 10 years. This is better done in younger patients. Those under 25 at the time of surgery had remained at significantly higher level of function than older patients. And physical activity was maintained a lot more in these patients, up to 75% of the patients than in microfracture patients. And return to sport was again much higher in these patients than in microfracture patients. Looking at a systematic review of these OATS patients with up to 10 years, the failure rate was still pretty high, up to almost 30%, with a reoperation rate nearly 20%. But the increased risk of failure was correlated with age, previous surgeries, as well as defect size. So the larger the defect, the older the age, and prior surgeries tended to increase risk, with decreased risk of failure correlated to concomitant surgical procedures such as offloading the defect with an alignment procedure, or performing an ACL or a ligament procedure to maintain stability. Now, if we don't take it from the patient's own knee, we can take it from a donor osteochondral allograft. And so this is a donor piece of cadaveric, fresh bone with cartilage on it. And the advantage of this is that we have a lot more bone and cartilage to use for these large defects. The disadvantage, though, is getting the availability, and the possibility for disease transmission because it is fresh donor tissue, with a very theoretical, low-risk possibility for a host reaction or a graft rejection. This has not been proven significant in the literature, and I've never heard or seen it before. The cartilage viability is always a question because this is fresh, it can be frozen, and whether those cells are still healthy in the cartilage or whether it's already starting to break off, it's a little unknown. We always worry about the integration. Your body has to then heal into this donor bone and take it over as its own, and sometimes that bond doesn't happen. And the longevity then is under question if it doesn't bond well, if it doesn't get blood supply, or then the health of that cartilage that you implant in. However, for large lesions, this is one of the only or best ways to do it, especially when there's bone involved underneath. So how do we do this? First, we try a diagnostic arthroscopy. We look at the lesion, we get the size, make sure it's appropriate. We look at all the other structures and make sure there's nothing else that's going to cause early failure. We open up the knee typically, and we find the lesion. This is a patient who had a osteochondral, an OCD, an osteochondritis dissecans lesion that was tried to be primarily fixed with a screw, but it failed. We then look at the lesion and decide the size with a dowel. We place a guide wire in it. We use a core reamer to ream out the bad diseased area, and then we measure. All right, so we're going to try this because I am going to be flying blind for a little bit, but we take the plug from the donor, we core out a plug and we put it into the lesion, and again, similar to the oats, we try to make the cartilage as flush as possible, and we don't want to hit the graft too hard because we want to save the cells, but we use little tamps to align the chondral surfaces just perfectly to make a smooth surface and get the bone to then hopefully heal in. We want to remove all the lesion in a circular plug, and then we can even do it in multiple areas of the knee, just multiple circular plugs all up and down. So if we get a large donor bone piece with a lot of cartilage, we can replace kind of large areas of loss in the recipient. And so this is a triple osteochondral allograft from the lateral or the medial and then the trochlea. Now, I think you see BioUni. This is a newer technique. So instead of a round plug, we can actually do an oval plug and replace one large area of the condyle in one sitting without having to do multiple circular grafts. And then for the very large areas of bone loss in young people, typically we can replace a whole condyle or part of a whole condyle in one basically one piece. And you can see on this slide the red arrows. The far left is a large area of avascular necrosis of the lateral femoral condyle, and you can see it being replaced with one large piece of donor bone where the red arrow is in the second picture with that one screw holding in place. But at the same time, we have to offload that area of stress, and so this is an osteotomy to distal femoral osteotomy in order to move the weight-bearing axis away from that donor bone to, give it a chance to heal. So osteochondral allografts, overall the satisfaction rate was 86% in the systematic review. 65% of the patients showed little to no arthritis at a final follow-up, and with short-term complication rates only 2.5%. However, an overall failure rate can be up to 18%, where cartilage can slough off. The plug may not heal.
And you can just tell me to go to the next slide. When you're ready to go to the next slide, we'll go to the next slide, and I'll advance it for you. And again, right now, we're on the slide that we were just on, the osteochondral allograft delivery of donor plug with the harvester device in the lesion.
Gotcha. So that's slide 54 on mine. Okay. So next slide shows a completed triple osteochondral allograft, as I said, in the medial femoral condyle and trochlea. Right? Next slide talks about BioUni. That's that oval plug that we mentioned. Instead of doing multiple circles, we can do one large oval plug. Should be the shell allograft, and that shows the where I said the 15-year-old where the whole condyle had avascular necrosis, so we replaced the whole condyle, but then we have to offload it with what we call a distal femoral osteotomy to reduce the stress on the graft and get it to heal. Next slide. So now we're at that systematic review I was talking about with an overall failure rate of 18%. Next slide. Another systematic review looked at 5 studies where there was a main failure rate of about 25%, reoperation rate into 35%. So this is not a slam dunk surgery. It's not something that has amazing, excellent results, but in these patients with major injuries to their knee, it is an option. It is probably one of the only options other than knee replacement at that point. Next slide. Now we should be talking about autologous chondrocyte implantation. Okay, so autologous chondrocyte implantation, instead of using donor cartilage, we actually can harvest cartilage from a patient's knee, usually a small little area. We grow it in a lab and then are able to then reimplant it into the patient, into the defect. So we transfer cultured cells back into a defect, and it's a 2-stage procedure, like I said. First stage is usually an arthroscopy, where we look at the lesion and get a cartilage biopsy, and then we send it to a lab, we grow it, and we bring it back and implant it. And this is best for when there's a symptomatic unipolar, as in one side of a joint, either usually on the femur, with a well-contained chondral shallow defect, so nothing that goes into the bone. And these can be relatively large. It could be up to 10 centimeters squared. And they're often used when other treatments have failed, like microfracture or abrasion arthroplasty, even some of these plugs or biocartilage. It is only authorized in patients age 15 to 55, though typically it's only 15 to probably 40. And so insurance would not cover it anywhere outside of that range of patients. And even to get authorization can be very difficult due to the price. Next slide. So ACI, autologous chondrocyte implantation, has progressed through 3 generations. The first was cells under a periosteal patch. The second was cells under a synthetic or under a membrane, which was porcine or derived from pigs. And now the third generation is these cells that are actually just implanted onto a membrane instead of injected under a membrane. And that's now the new technique, and it's much easier and much more reproducible. Next slide. So the advantages of ACI is we grow real hyaline cartilage of the patient, and so it's much more durable once it grows. It does not disrupt the subchondral bone like any of the plugs, so the bone stays healthy. And the patients can return to sport after this, once it's grown and once it's healthy. The disadvantages are that it's very expensive. Cells alone can be over $27,000. A patch can be over $40,000. And so this leads to some insurance hassles. It is a 2-stage procedure, so the patient needs to go in for 2 surgeries, one being the arthroscopy in order to get the cells, and the second is for the large implantation. And so recovery time, not only after the initial surgery, but after the second surgery, can be very long. It could be 12 to 18 months till they're back to full activity, with then potential overgrowth of the lesion where cartilage grows too much or bone grows, and then arthropfibrosis where they can get some scar tissue in the knee leading to stiffness. Next slide. So the biopsy, as I said, we go in arthroscopically and we take cartilage from the same areas where we used to take cartilage for the oats, like before, the far lateral or the notch, but we only want 2 tic-tac size pieces of cartilage. And we use these little curettes to grab them, and then we send them off to a lab to get put onto the patch. Next slide. So these cells are cultured in a membrane in some medium in order to get them to grow, and they're implanted onto a, usually it's like a porcine patch again, that's biodegradable. So once the cartilage grows, it kind of goes away. And it can be loaded with up to 1 million cells per square centimeter. And this allows those cells once they're implanted and they adhere and they're stimulated to then grow into new cartilage. Next slide. So after we get the cells and get it onto a patch, we open up the knee, and it has to be an open procedure. It's not arthroscopic. And we get a little, we cut out the bad area of cartilage, and we glue this implant in using, again, fibrin glue. And here it is, next slide. We prepare the defect by putting a thin layer of fibrin glue at the bottom. Next slide. We then put the membrane onto the area and basically glue it in. And next slide, we then glue around the border to kind of seal it in as well. Next slide. So looking at ACI versus microfracture, there's been some review of some high-level studies, and it shows that ACI is better than microfracture after 1 to 3 years, even up to 5 years. But then the clinical outcome of microfracture deteriorates, but the ACI doesn't, and it can be useful even up to 10 years plus. Next slide. Looking at ACI versus this OATS, where they take their own cartilage plug versus where we do it the membrane. ACI is far better with good to excellent outcomes in up to almost 90% versus 70% in the mosaioplasty OATS, even after 1 year, both clinical outcome as well as graft appearance. Next slide. Looking at microfracture versus MACI at 5 years, again, the MACI 90% normal or nearly normal versus 75% in microfracture. Next slide. Looking at meta-analysis, MACI showed superior improvement in patients in both their reported outcome scores compared to microfracture. Next slide. Systematic reviews show a failure rate's only about 10%, but some objective outcomes improve for both groups, whether tibiofemoral or patellofemoral, so it can be used in both locations. Next slide. All right, and one other thing to mention outside of all the other, this is another type of product, de novo, and there's others like it, where it is juvenile hyaline cartilage pieces, so donated juvenile hyaline cartilage harvested from a knee from birth to age 13. Majority are much younger. It's not fetal or stillborn, and it's a short shelf life, 30 days, so it's very fresh, and it has minimal manipulation, so it's only just kind of cut up but not pressed to hurt the cells. Next slide. So why would we consider juvenile cartilage? Well, juvenile cartilage has 10 times the amount of cells as adult cartilage, and the cell activity kind of decreases after that age 13. Next slide. So the advantages of de novo, it's no donor site morbidity. You kind of take it off the shelf. It's one-stage procedure. Once you see it, you can open it up and do it. You don't have to contour the graft. It kind of contours on its own. And it's reduced the need for any kind of major osteotomy or cutting the bone and realigning. Disadvantages, it's the theoretical risk of disease transmission, as it is donor tissue, and then cost is pretty high too, about $4,000 per pack. You may need multiple packs for the lesion. And overall, it's lacking much long-term clinical data, so it's still on the quote-unquote experimental type side of things. It is also used in the ankle for the small spaces there as well. Next slide. So as I said, we have to address comorbidities, not just the cartilage. So if there is malalignment, like we mentioned, we want to offload the areas with tibial or femoral osteotomies, like we've seen in previous pictures. We want to repair meniscal deficiency because the meniscus is a shock absorber and it will help offload the cartilage. So we either want to repair it or even transplant the meniscus. And we want to make sure the ligaments are stable so that the knee doesn't shift and cause instability, causing increased stress on the cartilage. Next slide. And if all else fails, there's arthroplasty. So when the joint space on an X-ray is already gone and there's chronic changes such as osteophytes, subchondral sclerosis, cyst, or deformity, or they failed other treatments, or they're on the older side of the age ranges as over 55, we can't really consider any of these other previous cartilage restoration techniques, so we can kind of lean towards arthroplasty. And that could be either a partial, where we just do one compartment if it's only on one side, or a total replacement where we can do all three compartments. Next slide. So which treatment is best? There's no, as we basically talked about, there's no one best treatment for all patients. We have to take all the variables into consideration and then decide what may be best for the patient. And we look at age, size and location of lesion, the activity level, any prior treatments. We want to consider non-operative treatment first. However, if they have mechanical symptoms, they're a young age, they're active, we may want to consider surgery earlier. We want to think about marrow stimulation as a first-line treatment because it's easy, it's cost-effective. However, long-term data is not that great. If it's a larger lesion, we may want to consider one of these other options. OC allografts, the large plugs, can be used as a salvage for large lesions, uncontained, with bone. And then there's always arthroplasty to consider. Next slide. So this is, I guess, what it all comes down to, my algorithm for what to do with knee pain and cartilage lesions. So a patient comes into the office, they have knee pain. We always get x-rays. We try to get 4-view weight-bearing x-rays if they can. If they already have arthritis on these x-rays, joint space loss, subchondral cysts, osteophytes, subchondral sclerosis, we typically just want to start treating them non-operatively. NSAIDs, physical therapy, injections, bracing, weight loss management. If they have mechanical symptoms, new mechanical symptoms, something like locking or significant catching, then we may want to consider an MRI. But otherwise, if it's just knee pain without those mechanical symptoms, an MRI is not needed off the bat. And it would be better to allow the treating orthopedic surgeon to decide whether an MRI is necessary. If they fail all non-operative treatments, then they can be considered for arthroplasty. Now, if we get the x-rays and there's no arthritis, then we see whether they have mechanical symptoms. Is it an acute injury? Do they have an effusion? If they don't have any of these symptoms, then we can also start non-operative with NSAIDs, physical therapy, maybe an injection, maybe a brace. But if they have any mechanical symptoms or an acute injury with swelling, we want to get an MRI to evaluate the cartilage, evaluate the meniscus, evaluate the ligaments, evaluate some alignment measures. And then we may want to consider surgery faster with these types of patients, especially if they do have a cartilage lesion, if they're young, if they're active. We don't want the cartilage lesion to progress to something worse that then may not be able to be fixed. Next slide. So my algorithm by age, if they're under 40 years old, as with all patients, they get an x-ray and possibly an early MRI. We want to consider all options to restore or repair the cartilage, as they are the age group that could do it with bone marrow. And we try to buy time before any arthroplasty. Even if they have larger lesions, we are a little more heroic in our measures. The age 40 to 55 is more of a gray area. As I said, there's cell senescence in the bone marrow. MACI is still somewhat indicated, but typically not a great option because it's such a big surgery. But they're still pretty young for an arthroplasty. So this is much more of a case-by-case basis as to what the injury is, what the patient's activity level is, what their desired activity level afterwards is. And in this age range, we can consider arthroplasty if they have severe arthritis if nothing else is working. And finally, in patients over 55, we always get an X-ray. An MRI is very rare unless they have those mechanical symptoms, new catching, locking. Repair and restore treatments are not indicated. And so we want to exhaust all non-operative treatments first: injections, medications, bracing, physical therapy, weight loss. And then when all else fails and they have arthritis, then we can then consider arthroplasty for them as our surgical option. And next slide, that should be it. That should be the end of the presentation. And thank you. And again, sorry for the technical difficulties there. And if there's any more questions, we can definitely answer them now.
And as a reminder, text chat is located on the right-hand side of your screen. To submit a question, type your question in the small text box at the bottom, and when finished, click the send button. Please note that due to time constraints, our panel may not be able to respond to all questions submitted. On behalf of Atlantic Health System, Morristown Medical Center Orthopedic Surgery, and the Department of Orthopedic at Clinton Medical Center, I would like to thank you for your participation in today's event. You will now be redirected to the post-event survey requesting your feedback. Please take a moment to complete the survey in order to receive credit for providing feedback and attending today's webinar. This concludes today's program. Thank you and have a great day.